Institute. Dr. Coates, a very accomplished investigator in the areas of HIV prevention and treatment. Perhaps we'll hear some about that today. And as I said, a very, very accomplished scientist and member of the Institute of Medicine. I can't really do justice to the accomplishments of either in a brief introduction, but I think you'll get the flavor. Dr. Lee Miller is Vice Chair for Education in the Department of Pediatrics in our school, and what's the correct title in relation to, is it Associate Director of Graduate Medical Education? Is that,
no title there.
Okay, no title there. Still important in GME, and one of the most accomplished educators, not only in our school, but nationally, very highly decorated teacher, and also extremely active in global health. We really appreciate their putting this material together today, being here for our lecture series, and I believe Dr. Coates will be speaking first. Thank you very much.
Thanks, John.
Thank you, John, and thank you for inviting Lee and I to come and speak today. We're going to turn the lights down. There we go. Hopefully we will have some pearls of wisdom for you if you're thinking about global health as a career. So what we want to do is 4 things. I'm going to speak briefly to introduce the Center for World Health. Then Lee will talk about potential ways in which you can contribute and grow in international settings, and he will talk about his personal experiences. We're going to talk about the impact of lessons learned on international health experiences, and then finally I will come back and talk about opportunities for partnering with the Center for World Health. So first, the introduction of the UCLA Center for World Health. Our catchword, our byline, I guess, is saving lives and improving health by investing in people. There's a lot of talk about it, particularly in the World Health literature and in the development literature, about sustainability. And there's another line of talk too, which I think is very, very exciting, and was put out in a special issue of The Lancet, which is free and downloadable, called Global Health 2035, Convergence Within a Generation. In the last 20 years, there's been a very remarkable change, and that is the majority of the countries in the world in 1990 were classified as low income. By 2011, that had decreased to about 36%. And they expect within the next 20 years that it might be possible that there is convergence, that the lowest income countries of the world converge with the middle and high income countries of the world, particularly in terms of longevity, in terms of access to services, in terms of public health infrastructure, and in terms of decreases in below 5 mortality and decreases in maternal mortality. And that's eminently achievable. It's a little known fact that life expectancy in Mexico is now the same as life expectancy in the United States, and a lot of that has to do with decrease of under 5 and infant mortality. So these things are achievable even as countries grow economically. The other point that's made is that as we invest in health, it's good for the overall economy. Investments in health lead to overall growth in gross domestic product. And as you can imagine, what it means is there's a healthier workforce that's going to live for a longer time and be more productive for the society. So there are a lot of reasons to be optimistic, and there are a lot of reasons to make contributions. And we're questioning and we're asking the question, what can we at UCLA do? That's why we call ourselves the Center for World Health and not the Center for Global Health. Global health implies interest in low and middle income countries. We're interested in those countries, but as the world changes, as there are more Chinas and Russias and South Africas and Brazils of the world and Indias, Vietnam has now become a middle income country. Rwanda is celebrating the 20th anniversary of its terrible genocide. It will be a middle income country by 2020. The world is changing. We're interested in the entire world, and we're interested in reducing those disparities. We define our core values. We're humanistic. We care about health and human rights as a good in and of itself, as an end in and of itself. And health is a fundamental human right, and access to health is a fundamental human right. We're worldwide. I talked about the rationale for low, middle, and high income countries of the world. We believe in sustainability, and we believe that the sustainability comes by investing in the people who live in a particular place. It's their country, it's their place, and if they have the opportunities and the skills and the capacities, that will sustain the health gains in those particular places. We appreciate diversity. I talked to the incoming class of medical students, and about, I would say, a good 40% are born in countries other than the United States, and a good many, a majority, speak a language other than English at home. And we celebrate that diversity, and I'm glad we do that here at UCLA. We're horizontal. A lot of academic medical centers have global health programs, and sometimes they look rather colonial. You go to their website and you see pins on a map, and it looks like who's got more pins on the map and who's in more places. We don't like to work that way. We're horizontal. We engage in partnerships. We ask about those partnerships. We ask what those partners want from us. We ask what we can contribute to them. Dr. Miller will talk about Mozambique, and this is very much the way he engaged in Mozambique, and we're proud of working that way. And of course, innovation is important. Now, I want to talk briefly about our 4 priority areas. Global Health Education Programs, which Lee directs, is designed to develop, sustain, and support a new generation of leaders, both for our medical professionals here in training, as well as with our partner institutions around the world. And we do that both by capacity building where we work and bringing people to UCLA and allowing our students the opportunity to work in other countries. We've well established the first building blocks of this, and that is programs for the medical students and the global health pathway, as well as many residency programs. There are residency offerings in World Health now in medicine and pediatrics and ophthalmology, and dermatology is working on developing opportunities. OBGYN has opportunities, surgery, orthopedic surgery, and other programs are coming on board. Family medicine, as I mentioned, and hopefully other programs. And then perhaps moving toward a global health fellowship as we get the first 2 pieces in place. International clinical initiatives to strengthen human capital means that we are trying to contribute. UCLA's contribution to this grand convergence is helping to build a skilled and patient-centered workforce around the world. The third area, World Health Policy for real-world impact. The best example of this that we have is a little-known fact that the leader of the HIV program in China is a UCLA graduate. Roger Dietels, who holds a joint appointment in public health and medicine, has for years trained the leadership in Asia. Now, China has one of the best HIV programs in the world. He introduced needle exchange and methadone maintenance and outreach to men who have sex with men and outreach to commercial sex workers, and it's been a huge success and free treatment for all. An example in Mozambique, through the work of Lee and Dan De Ugarte, has been modification of transfusion guidelines for pediatric surgery. In Malawi, we've contributed to the development of the National HIV/AIDS Guidelines. Obviously, we're interested in scientific solutions, and HIV has been the window through which we've been able to expand our programs in many parts of the world. We have great interest, and are looking for strategies to develop beyond that, and think that we could make a very strong contribution in the area of liver cancer in Asia and cervical cancer in sub-Saharan Africa. And of course, there's the growing problem of non-communicable diseases, chronic diseases in many parts of the world, and particularly in the low and middle income countries of the world. They have this double burden of the infectious diseases and the non-communicable diseases. And then finally, we're looking for technology solutions to connect worldwide. We think at the end of the day, the thing that makes a difference is human connections. My mentor in World Health was Haile DeBas. Haile was the chief of surgery at UCSF and then became dean and chancellor. And he said, you know, we Africans, we like eyeball to eyeball. And it's really the human connection. And we can use technology now to have human connections. And we want to figure out ways to do that. So we want to save lives and improving health by investing in people worldwide. I'd now like to turn the podium over to Lee Miller to talk about ways that we can all contribute and move from there. And I'll be right back. I'm going to go down and get some brochures and not just the single pages, so I'll be right back.
All right, thanks, Tom. So Tom has hopefully set the stage, the 30,000-foot stage for the mission of the Center for World Health and some of the priorities. And now I'd like to to come down to maybe the 10,000 foot level and say, what is it that we may choose to pursue as faculty members? And there are many different ways, lots of potential for us to get involved in different arenas. And I'm going to try to illustrate that with some personal experience. And I'm going to introduce the opportunities for us to use our areas of expertise within medicine to teach in international settings. And the example that I'll share with you will be related to some work with the WHO on oral rehydration. I'm also going to introduce the opportunities for us to do clinical work. And the example that I'll share is some work during the Rwandan Civil War in refugee camps. And there are many opportunities for all of us as faculty members to pursue assessment experiences, and I'll share one in which I participated in Kabul, Afghanistan. And really the overarching theme is that the Center for World Health is now established well enough to provide guidance and connections and mentorship for any faculty members that may want to run in any of these arenas. And I'll talk a little bit more detail about opportunities as teachers, as clinicians, and as assessors, and share a little bit more about what we're doing in the center. And then Tom will also, at the end, bring it home with some more opportunities for us to pursue scholarship and other research opportunities. So first, I'm going to zoom in on a particular experience that I had with the World Health Organization, and I had a sabbatical that was related to the management of diarrheal diseases. And just to set the stage for this project, at the time of my sabbatical, diarrheal diseases were the #1 killer of kids worldwide. They're now #2, a close second to respiratory illness, but it's still way up there. And we hear large numbers like 10,000 children dying every day, and that's hard to bite into, but that translates to 7 deaths a minute, which is really pretty outstanding. So given this overwhelming morbidity and mortality, the WHO has put so much effort into training healthcare workers around the world to use simple electrolyte solutions that are life-saving. And my project was to carry out training workshops at medical schools all over Africa. And first, we made sure that the clinicians were aware of the appropriate use of these oral rehydration solutions. And then the much more fun and creative portion of the workshops was to help them with innovative ways to incorporate this into their medical school curricula. And we did these workshops all over the world, and I'll just share one training example with you. And this was a workshop that we did in Addis Ababa, Ethiopia. And despite the healthy appearance of this child, we saw an incredible spectrum of pathology over there. This infant presented with severe dehydration, and a closer look on this next image, you can appreciate his malnutrition, his severe tinting of the abdominal skin from decreased skin turgor, and also very significant thrush likely related to T-cell immunodeficiency. This child had severe kwashiorkor or protein malnutrition, and a close-up of his feet demonstrates his peripheral edema from hyperproteinemia. So there are really many, many ways in which we can all get involved with different groups around the world, including relationships that the Center for World Health has to pursue teaching or training opportunities within your areas of expertise. There are even more opportunities to pursue clinical work, and those are really limitless. And I'd like to share just a bit about a clinical experience that was very powerful in my life, and that was related to the Rwandan Civil War 20 years ago and the genocide that occurred at that time. There were thousands and thousands of folks that were murdered in that chapter, and millions of Hutus that were fleeing Rwanda at the time. So here is Rwanda in South Central Africa, a very small country. The capital city of Kigali is here, and the Hutus were fleeing to the border town of Goma, Zaire, which is now the DRC, the Democratic Republic of the Congo. And they chose Goma because it was another country, so they were getting out of Rwanda, and they chose it because there's a very large lake there, Lake Kivu, and they thought they would have a great water supply there. And here is a picture of Lake Kivu, and you could see the lake is on the right, and this is actually at the the Rwanda-Zaire border. This was unfortunately a terrible choice for the refugees. It was really very unfortunate because the ground in Goma is volcanic, and volcanic ground in a refugee crisis is disastrous. And one of the main problems is that you can't dig latrines, so all the human waste ran into the water supply. And the second problem with volcanic ground is that you can't bury the dead. So there were above ground mounds of bodies that gradually slipped into the water supply. So it was a disaster with millions of refugees arriving in Goma. They arrived hungry, thirsty, weak. It was presumed that there was about a 30% HIV positivity rate amongst the population, and there was a request for a pediatrician to help in the camps given the massive outbreak of cholera amongst the children there. So I had an opportunity to go down and work in the camps, and this is what I was faced with my first morning at the clinic. That was the line that was backed up behind the medical tent, and each day there were countless bodies that were found dead. And as I mentioned, that created an immense public health catastrophe. So what were the major medical problems that we faced as clinicians in the clinic? Acute watery diarrhea and dehydration were really the most significant. It was the number one cause of death. There was a massive epidemic of dysentery from Shigella. We also had a huge outbreak of cholera. There was a very high incidence of pneumonia, and as you'd expect, severe malnutrition. We saw loads of parasites, and you might be able to see the ascaris on the far left. There was lots of trauma with folks fighting over food and water, and there was, of course, malaria. And as if all of the above were not enough, there was an outbreak in the camps of meningococcal meningitis. And there's a summary of the major medical problems that we faced. We also had a huge problem with new orphans, as every day more children would crawl out of their mud huts seen here. So this is where the refugees were living. We gave them these green tarps to try to stay warm at night, and also to try to keep the mud huts intact because the monsoon rains were about to start. And every morning we saw these kids crawling around because overnight their parents died. And they were crawling around hungry and thirsty, and there was no one to fight for them on the food line. So there was a tremendous refugee problem as well. We had many significant obstacles to address these problems, and first and foremost was the poor availability of clean drinking water. And imagine the stress of having to walk through the fields as a physician with a very limited amount of clean water and having to decide which children to give the water to. And we were literally turning kids over to see who was alive, who wasn't alive, who were the most toxic children that perhaps wouldn't survive the night without water. And it was a really terrible experience to have to refuse water for the moms who were begging for their children. And those faces and those cries are really indelibly imprinted in my mind. And there's really so much more that I could share about this chapter alone. And I'll just say for now that I returned to UCLA having experienced an unimaginable and painful dose of human misery and suffering. But they don't all have to be that intense, and there are many, many other wonderful clinical experiences in which I've participated. And should you decide that you would like to have opportunities in the clinical arena in any of your areas of expertise, the center would be absolutely delighted to try to make the appropriate connections and facilitate that for you. Well, there's a third category of opportunities that you might consider given your expertise, and that's related to an assessment chapter, an assessment experience. And I had an opportunity to do an assessment project at a public maternity hospital in Afghanistan. And this is a quick view of some of the local clothing and the location on the map of Kabul. This was not an easy place to get to during the war. I flew commercially to Dubai and then took a United Nations humanitarian plane over to Kabul. And this is what I arrived to, the city seen here. Most of the roads are not paved. Many of the buildings were bombed out from the war. Much of the city had no running water, and there was no electricity anywhere after 9 p.m., lights out. This photo shows the very typical dress and background architecture, and of course the curiosity of children that's really so universal. And my project there was to review and assess the newborn care provided by general pediatricians at this public maternity hospital, Rabia Balkia. Rabia Balkia has about 14,000 deliveries per year. That's a massive number of deliveries. So that's about one every 30 minutes. And I just want to explain the conditions in which these deliveries are occurring. And I'll highlight that these are the lucky moms that are delivering here, because 85% of the deliveries in Afghanistan occur without anyone who's medically trained. So for the, quote, lucky 15%, they arrive at Rabia Balkia usually in active labor with no prenatal care. The women are completely covered in burqas. It's a Muslim country, and they're escorted into the delivery room, which is just a room that has rows of flat metal tables without stirrups. They don't get completely undressed. They, oh boy. Oh, it's good for you there. Okay. They don't get completely undressed. They just pull up their burqas and they lie flat on the table and deliver those babies. And as soon as the baby is born, a timer is started. And they have exactly 2 hours post-delivery to stay in the hospital. Every mom who comes in labor is required to bring a blanket or a towel with her that she can wrap the baby up in. And 2 hours later, they give the baby back to the moms wrapped in the dirty towel or blanket that they came in with. And tightly wound with a spool of rope, really, to keep the baby snug and warm. It was the winter time. Mom sits up on the table, she drops her burqa, she's handed the baby, and she walks out of the hospital 2 hours later with no follow-up care for mom or for baby, usually dripping blood in the snow on her way outside of the hospital. And these are, the lucky 85% who are delivering with a trained the lucky 15%, as 85% are delivered without a trained medical assistant. And given those conditions, it's not surprising that the neonatal morbidity and mortality in Afghanistan is amongst the highest, if not the highest now in the world, with an overall infant mortality of 142 for every 1,000 deaths. The major causes of neonatal deaths are listed here: birth asphyxia, birth injuries, sepsis, congenital malformations, and neonatal tetanus. And there's a lot of consanguinity in the community there, which explains the very significant incidence of birth defects. Despite the odds, though, and the very limited supplies, the local physicians were so committed. And I feel in our own small way, we were able to make some general pediatric recommendations to improve the care of the children that are born in this hospital, and it was a very rewarding assessment experience. So in summary, I've just shared one personal example of ways in which in each of the following categories, and ways in which you folks may choose to get involved in the global health arena. There are training opportunities, there are clinical opportunities, and there are assessment opportunities. So over the ensuing years after these three examples, I spent a fair amount of time exploring ways in which I could combine my three professional passions, and one of them is, of course, is teaching medical students. That's number one. Second, taking care of children, and three, running with my global health interests. And 6 years ago, along with some close friends and colleagues, we established a new nonprofit under the UCLA umbrella, and it's called Partners for Pediatric Progress. And our mission is to improve the health and care of infants and children in some of the poorest regions of the world through training activities to build local capacity. So it's the ultimate teach them how to fish rather than fishing for them, to make a sustainable impact. And at the same time, given the relationships that we're establishing with our partners, we're using these sites and relationships to provide really very fine educational experiences for our medical students and for our residents, and thereby nurturing the interests of the next generation of public health leaders here at UCLA. And this is all done under the umbrella of the Center for World Health. And I think I'm going to go into a little bit of, spend a few minutes on what we're doing with Partners for Pediatric Progress, because I think it's illustrative of the many opportunities for our faculty. There are research opportunities, teaching opportunities, training opportunities, assessment opportunities, and lots of room for scholarship. We have two major partner sites. One of them is in Mozambique, and the other is in Iquitos, Peru, and that's in northern Peru in the Amazon region. And this is about a 2.5-hour flight northeast from Lima. Iquitos has been described as the densest city in the world with no road access. It's an island city, so the only way in is by boat or by plane. And the medical community serves the 500,000 population of the island, but it also serves an additional 500,000 folks who live in very rural communities. So imagine branches of tributaries of branches of the Amazon going to small remote villages, and some of the patients that we see at the hospital in Iquitos have traveled by boat for over 2 weeks to reach medical attention. So the population that is being served there is really extraordinary. This is the slum community of Belin in Iquitos, and this is where we've established some of our local training activities. We actually have 3 medical students that are there this week finishing up their clinical electives. And the students also have an opportunity, in addition to working in the clinic, built on stilts on the Amazon, they're also working in the regional hospital. That's the referral base for this whole northern portion of Peru. And our students learn so much about dengue, malaria, leptospirosis, dealing with snake bites. There are anaconda posters all over this region, but they come back really having learned so much more than that I'll emphasize in a moment. Our other partner site is in Mozambique, in the capital city of Maputo, seen here on the southeast corner of the African continent. And it's hard to really appreciate this next line without seeing the whole map. But this coastline on the Indian Ocean of Mozambique is actually longer than the west coast of the United States. So if you were to stretch out the U.S. from San Diego to Seattle, the Mozambican coast is longer, and most of this coastline out of the city is really magnificent white sand, unspoiled, untouched beaches. Despite the beauty of the setting, Mozambique is one of the poorest countries in the world. It ranks at the very bottom of the United Nations Human Development Index, and for perspective, currently the majority of Mozambicans' population of 20 plus million live on less than $1.25 per day. And Mozambique currently has 10 million children. When we started working in Mozambique 6 years ago, this number was 10. So there were 10 million children and 10 pediatricians in the entire country. We're now up to 50, and this number of pediatric surgeons was 0, and thanks to Dan and the program that you'll hear about in a moment, that number has jumped up to 2 pediatric surgeons for the 10 million children. To give you a feel for the setting, this is the Eduardo Mondlane University Medical School. It's the main medical school of the country on the left, and this is the Department of Pediatrics or Children's Hospital at the main teaching hospital. The main teaching hospital has about 1,500 beds, so 3 or 4 times the size of Reagan, but an average daily census of 3,000 in the rainy season, and pediatrics alone has a few hundred beds. This is one of the roads that leads up to the hospital, and this scene is pretty typical of African hospitals where family members wait outside to see their loved ones. And here's a quick glimpse of one of the rooms on the pediatric ward and the local house staff and residents rounding on patients. The partnerships that the Center for World Health has established are in multiple areas. There are clinical partnerships, in particular in peds critical care, surgery, radiology, and cardiology. We're working on an infection control project. We have multiple medical education partnerships with residents going in both directions, and we have pursued a fair number of research opportunities and a fair amount of scholarship. Just to give you a few examples, we're within this main teaching hospital. This is the main nursery service for the hugest teaching hospital in the country. There are 70 babies in there, and there are 35 in one room, 35 in another, and 1 nurse in each. So 2 nurses caring for 75 babies. This is actually a nurse from here in California who was raised in Maputo during the Portuguese occupation, and she is participating in our program doing teaching. This is the nursery in the country, and there is a 33% mortality in this nursery. Another of our projects is in the Pediatric Critical Care Unit. We've established a training program with our colleagues there through the Center for World Health. And this woman, Dr. Valeria, is the one pediatric intensivist in the country. And the program with Valeria is illustrative of the model that we've established. We've sent UCLA faculty members from here to Maputo to do an assessment and initial training activities. And now Valeria is here in Los Angeles with us for a month of training. And then Rob Kelly, our pediatric intensivist that was there previously, will then go back to Mozambique. And that's the way we've set up these sort of bi-directional twinning partnerships. To give you a feel for the things that we're dealing with in the unit, there are many patients with Erasmus. There are many children with HIV, AIDS, and the common comorbidity of Kaposi sarcoma, as you can see on his skin here. There's also a tremendously high incidence of tuberculosis in the hospital and in the ICU and in the community in general. And this poor guy had 3 terrible diagnoses with marasmus, HIV, and tuberculosis. These images set the stage for another common diagnosis in the PEDS ICU, and this is, of course, severe burns. The mortality rate of burn victims is really quite high given the very poor infection control in the hospital there, and also the very limited local expertise, which brings us to our pediatric surgical training partnership that's been led by Dan Diagarte. And Dan is seen here with Dr. Atanasio, who is really the first pediatric surgeon in the country for those 10 million kids. And when we started our program in Mozambique, there was no pediatric surgeon. There were 18 adult surgeons, and the Ministry of Health asked the 18 surgeons, which one of you wants to be a ped surgeon? Atanasio volunteered, and that was about the time when we met, and Atanasio said, I am desperate for training here in Mozambique. It's not as helpful to send me to Europe or to North America where I don't have a license, I don't have privileges, and where the technology is far more advanced. I need surgeons here to walk my fingers through the cases, to think through the differential diagnosis, to help me deal with the complications, to do the surgery with the antiquated 1950s equipment that we have here, not what you have in the States. Well, Dan was a former med student and an old friend, and I came back to LA and told him about this project, and Dan said, let's go to Mozambique. So we went to Mozambique, and he had a great connection with Atanasio, and Dan and I have become close partners and dear friends on this project together. And he's done amazing work because he's not only trained Atanasio, but he's trained a second pediatric surgeon. And again, in this model, Dan coordinated training trips for U.S. pediatric surgeons to go to Mozambique on almost a quarterly basis. So Atanasio knew that every few months he was going to have another pediatric surgeon there to spend a week or two to walk him through the cases and reinforce the training of the predecessor trainers. We also brought Atanasio from our CDC PEPFAR grant to Los Angeles to spend a month of training here with us. And after 2 years of training visits, the feedback from our faculty has been that he's really excellent. He's technically been great from the start, and he's learned so much pediatric surgery, and he has now taken the lead to train other folks. And you could see here, there's Dan with Atanasio, and Vanda is on your far left, and she's the second pediatric surgeon in the country. And just like Atanasio, she had an opportunity to come here and train with Dan and his colleagues just a few months ago. Now, Dan, in addition to leading the training efforts for the only 2 pediatric surgeons in the country, Dan is setting the stage for planning a surgical center of excellence for the country with a burn unit. And this is a lofty dream, and it step by step it seems to be coming to fruition, and it will be an amazing contribution to building capacity and improving the care for children in the country. We've also been using this relationship as an opportunity for mentoring students and residents and for mentoring research projects. And I'll give you just an example of one, but one of Dan's early realizations in the operating room is that none of the kids were getting, or hardly any of the children were getting their perioperative antibiotics that they needed, and they were almost all getting preoperative blood transfusions when they didn't need it. And when asked why, there were not many Mozambican anesthesiologists, and mostly expat folks from China and North Korea, maybe Cuba, and they're losing blood, so they need blood, and Dan said, let's study it. So a couple of our first year, rising second year medical students through the STTP program went to Mozambique and spent a month in the operating room, and they recorded all the blood transfusions that were occurring with children and the preoperative hemoglobins on these kids, and they analyzed the data, and there are formal recommendations from the WHO on transfusion thresholds in low resource settings with high-risk blood transfusions, and over 90% of the transfusions were not necessary. And these data were brought to the CDC, who in turn brought it to the Ministry of Health, who got all excited and said, we need a national transfusion protocol, but we don't have the expertise. Dan came back to LA and recruited Alyssa Zyman, who runs our transfusion service, to go over to Mozambique, and Alyssa is helping them to write their national transfusion protocol, and at the same time is training one of their physicians to run a blood bank. And one of their physicians was here with us for 4 months of a mini fellowship and is now running the National Blood Bank in Mozambique. The students wrote this up. They had a chance to present it at a national surgical conference, which happened to be in Hawaii, that we sent them off to, and they wrote this up. And here we have 2 first-year medical students as the lead authors for an article in transfusion medicine. So we're really very, very proud of them, and I think that it's illustrative of some of the opportunities for scholarship, not just for the students and residents, but also for us as faculty members. So in the last minute or two that I have, I just want to share a little bit about the impact of the lessons learned from these international health experiences, and some of them are more obvious biomedical ones, but some are less obvious. They're the educational benefits, learning about tropical diseases and different healthcare systems, improving our physical diagnosis skills, working in settings with fewer diagnostic resources. We all come back with a better appreciation for cost barriers and patient care, and I've no doubt that our students come back with more humanism, cultural sensitivity, and a greater commitment to working with underserved populations here at home, and really nurturing those qualities and attitudes that we try to nurture in our students from day one. We've had a fair number of students and residents turned on to careers in global health, and the last one, number 7 on the list, is really the take-home bang point here, and that in addition to all these biomedical things and opportunities, each of these experiences for students, residents, faculty, for all of us, they are powerful reminders of our relative good fortune in the world, both personally and professionally. And for me, that dose of perspective is priceless. And every time I come back from one of these experiences, I'm reminded of how fortunate we are in our lives, both personally and professionally. We get so wrapped up in things on a day-to-day basis, and we sit on the 405 and we're in bumper-to-bumper traffic and we're grinding our teeth. But all of those things are really so unimportant in the grand scheme of things when we get this dose of perspective. So I think we all come back changed. And our students, residents, and our faculty, we learned about things like the scourge of HIV that has ravaged so much of the world in Africa, but we have such powerful lessons that are not just biomedical lessons, but systems-based lessons and cultural sensitivity lessons, and all of the ACGME competencies are reinforced over and over again for us. Imagine the lessons learned for one of our medical students, residents, or really for any of us, when a young man hobbles into the clinic with Kaposi sarcoma, and he shares with us that he's no longer able to work in the farms and can't support his family anymore. The cultural sensitivity required to deal with such a patient, while the magnitude is different, it's not very different from what we strive to teach our students here at UCLA. Imagine the dose of perspective we gain when a mom carries her baby in from a rural village, and she's walked for days in a country with 10 million children and now only 2 pediatric surgeons in the country who can address this problem, or the interpersonal and communication skills required to connect with this scared 12-year-old patient with TB peritonitis. So we have built upon this program in Mozambique and many others within the Center for World Health to support educational and training experiences for not just the students, residents, and fellows, but there are really limitless opportunities for faculty members of all levels. And I think that's one of the reasons why Dr. Hyatt wanted us to share with you some of the opportunities within the Center for World Health. So Tom started out by giving you a sort of 30,000-foot feel for the priorities of the Center for World Health and the mission statement. I've tried to walk you through different ways in which you may choose to get involved in the global health arena, whether it be a training experience, clinical experience, an assessment experience, and then shared with you an example of a multidisciplinary project in pediatrics and surgery that has nurtured medical student, resident, faculty development, and scholarship. And Tom will spend the next 15 or 20 minutes just giving us a little bit more information on the Center for World Health and also addressing some of the opportunities for scholarship.
Thanks, Lee. That was wonderful, as usual. Wondering, how do we turn the lights up? Right. Ah, wonderful. So now I have proper brochures. Maybe we can pass these back. So I wanted to talk just for a few minutes about how we might help you if you're interested in global health, world health, how we might help you. Well, the first thing you should know is this email address, Ashley Crane. And if you're interested in just learning about our activities, Ashley can put you on the listserv. And we send out every Monday an announcement of the things that are happening at UCLA and beyond. We also list things going on at USC and other institutions nearby that might be of interest. This is for general educational purposes. In the fall, we offer a Global Health Selective for the first and second year students. And our idea there is to try to expose them, if they're interested in particular specialties, to expose them to what those specialties might be able to do in global health: emergency medicine, surgery, ophthalmology, pediatrics, infectious diseases, endocrinology, whatever the specialty they might be interested in, emergency medicine, how they could envision themselves having a global health career in any of those specialties. We also offer a number of discussion groups at my house. We usually hold those about once a month or twice a month in the fall, depending on the speakers we have coming through, to allow the students as well as the faculty really learn and have the opportunity to discuss in depth an issue related to world health. We also want to play the role of matchmaker, and that is, if you're interested in global health research, if you're interested in global health education, if you're interested in global health clinical opportunities, if you're interested perhaps in seeing what it might be like and to learn about global health career opportunities, whether it be through the US government, the CDC, USAID, the Department of Defense, through multilateral institutions, the various UN institutions. If you're interested in learning about what those opportunities might be like, this is what led Lee to the career that he has, was an opportunity to work with the World Health Organization. We can help you understand the landscape, as well as help explore how you might explore some of those opportunities and seek out those opportunities. If you're interested in research, we also can play the role of matchmaker. We like to connect the dots. And we are in the process of getting our website to go live. It should go live within the next month. We have listed on that website and we've culled together everything that we know about so far, and there will be more that we will learn about, that will help to just be a repository of the educational, the service, the partnership, and the research activities that are occurring with our faculty and with our and with the service providers within UCLA Health. So either through the listserv or by coming and talking to us, we're happy to play the role of matchmaker. I got an email today from a fellow in digestive diseases who's interested in the effect of cannabinoids on various digestive diseases. And did I know anyone who would have any expertise in this, particularly as it applies to World Health? Well, I was able to connect her up immediately with Walter Ling, the director of the Integrated Substance Abuse Program in the Department of Psychiatry. And Walter this is one of his areas of expertise. He does work in Vietnam, in China, in South Africa, and they're doing also work in the Middle East. And medical cannabinoids is one of his areas of expertise. So we can play this kind of matchmaking role for people who are interested in research. We can also help you learn about other opportunities, be it fellowship opportunities, be it advanced degree opportunities. We're available to help with those kinds of relationships. So I guess the thing is, contact Ashley, contact me, contact Lee. We're happy to talk with anyone and help them think about what those opportunities might be. Everything from what if you have a general interest to a very specific interest, and we're glad to do what we can to help you do that. So we have about 5 minutes left, and maybe we could see if there are any questions.